Great. Welcome back, everybody. We'll start with a couple questions for the afternoon folks. And maybe we'll kind of kick it off with a little
Mike, as you kick it off, you want to just introduce our one new panel member, because I think they probably need to be introduced to
yes,
Klein.
As Marina Klein is joining us. She's a physician researcher out of Montreal, Canada, McGill, and has done an awful lot of work on HIV antiretroviral therapy and treatment of patients, but now has sort of also shifted into PrEP like a lot of us have. And so welcome. And you can bring the perspective of you along with Jean-Michel to a healthcare system that is not quite as convoluted as what Dr. Crowley just had to cover. So, so there we go. First question, Susan's for you. The CDC HRSA focuses on hotspots, and that makes sense, but has an unintended consequence of reducing funding opportunities for areas that are assumed to have lower incidence. And so your thoughts about how that can be evened out a little bit. That was from Adam Spivak in Salt Lake City.
Yeah, I think that's a real issue. Even though these 48 jurisdictions and the 7 states account for about half of the new infections, we still have infections happening in the rest of the country. And so we really do need to advocate for CDC to expand their ending the epidemic approaches to include these other areas, because it does have this unintended consequence of actually there's still about half of the new infections that are occurring outside of those areas. And even though they wanted to really prove that you could focus in on those populations and really try to turn the curve, we do need to expand beyond that.
Yeah. And Monica, Adam had a follow-up question on just a question about pharmacist-led PrEP efforts to try to expand us, get us out of, I mean, Jean-Michel said that they're doing most of their PrEP activity out of a hospital. And is that a way that we might be able to move to expand the reach?
Yes, there is actually California law that was sponsored by Scott Wiener, who's really a credible champion for PrEP here in the state, to have pharmacy-led PrEP administration. So we, for example, I think Dr. Buchbinder talked about Mission Wellness as actually a specific pharmacy that they keep track of your prescriptions. They'll call you, it's time to come in to get it. I'll deliver it to you. We'll do monitoring. So time to go and get your monitoring. Like, it is absolutely almost completely pharmacy-led. And we are hoping for this kind of dream of the IM cabotegravir. Also, I mean, pharmacists can administer intramuscular medications. And I think one way to expand it is there's going to be a program someday where we can self-administer, hopefully, if people can be trained. That's a little harder, but we're thinking about it. And then pharmacy-led intramuscular cabotegravir.
Great. And then Jeff, I'm going to combine a bunch of questions here into one, and that is a little bit of clarification that Medicare Part D, will that cover PrEP? And is that sort of an active thing? And similarly, did you say that the ACA will pay 340B for PrEP, not to Ryan White clinics necessarily for that, but to other clinics that do STI and other type of work?
Yeah, so Medicare is not covered by the USPSTF recommendation, but Medicare offers prescription drug coverage through Medicare Part D. So people that have Medicare Part D, that program covers PrEP. There's a special protection for 6 classes of Medicare drugs, including antiretrovirals, that all Medicare Part D plans must cover all or substantially all drugs in the class. So all the medications must be covered. So, and the labs and other things are covered under other parts of Medicare. So the services are covered, but there is cost sharing in Medicare Part D. So if you're a PrEP user in Medicare, you'll have to pay cost sharing like other drugs, but PrEP will be covered. Now, it looks like a question, or keep going?
No, keep going.
No, and so then the question is 340B clinics, these other ones, other than those that just get Ryan White funding, can use their 340B program income for PrEP services. Yep, yes, they can do that. Now, the ACA question is, so people have insurance coverage through the ACA, and in some ways that's less relevant. So if people with their insurance are allowed to go someplace and they're allowed to use a 340B pharmacy, that pharmacy can get reimbursed at the regular rate that they would pay anybody else. And they had purchased a drug, and that spread, that program income, they can use. So it's the fact that they have insurance. Now, ACA insurance might limit where you're able to fill your prescriptions, but that's not really a major issue. If you have private insurance, yes, if you go to a 340B pharmacy, they can generate program income from it.
Yeah, I mean, it's clear when I think we all hear you say this, but wow, is it hard to keep straight? I think I might end up signing up for the French or the Canadian programs here. It might be a little easier. But that's why we have you, because it is complicated, but you did a great job of making it clear. And I see Dr. Landovitz has joined, and he's got his headphones on to help direct air traffic control at LAX. That's great. Welcome back. Whoa. Perfect. Henry.
Whenever I see a question from Amanda Cassell, we have to respond to that since she's the leader in the DC effort, but she wants to know when the CDC PrEP guidelines are going to be revised. Does anybody have any inside information about that?
I know that they were out for public comment and then went back in. The last time I spoke to Dawn Smith, she assured me that they were imminent, but I don't have a more specific timeline.
All right, here's a specific question about PrEP and Dexa scans. I guess maybe somebody could comment on how often they use Dexa scans and whether there are any legal implications for long-term PrEP and complications like bone complications. Anybody want to take that on? Or maybe I should add, maybe I should
actually, Henry, I might take a shot at that first. And I think that the use of Dexa in otherwise healthy 25 and 30-year-old folks, especially men, I'm not sure what that means, because Dexa is really meant to detect osteoporosis in older populations. That's how it's normalized. And so if you see a 1 or 2% change in somebody who's 25, especially if they're men, I don't know what that means. Does anybody have any sense that that's evil? Jean-Michel, do you have any ideas on that?
Well, we don't do bone scans at all in people on PrEP. And according to the data from, there are a lot of data from, a number of studies, especially among MSM, where you could see that the decline in bone mineral density actually levels off after 24 weeks, 48 weeks. So it's the first 24 weeks when you see a decline, and if you stop PrEP, then it rebounds to most participants to the baseline level. So the real, I don't think there is an issue here, except potentially in older people who have, additional cofactors for osteoporosis or osteopenia. Other than that, I would not do a bone scan in people on PrEP.
Marina, what are your thoughts there? What do you do in Canada?
No, I agree entirely with Jean-Michel. We're not doing it routinely, certainly not for younger individuals, unless there's some particular risk factor.
Right.
I think the one thing just to keep in mind is, while Jean-Michel is of course 100% right that there's return to baseline bone mineral density 6 months after stopping PrEP, the one population in whom that doesn't seem to be true are youth and adolescents who are still accruing bone mass. And we know even less about what that means or how to interpret DEXA data in that population. But it is that population in particular, I think there are some unanswered questions about impacts on long-term skeletal integrity.
Yeah, that's a good point. And Jeff Kirchner wrote to us on the chat to everybody and said that that Dawn Smith a couple of weeks ago said that she thought that end of the month or first part of December, a couple of weeks, it'll be out, the CDC guidance. Henry?
I mean, Susan mentioned some innovative approaches to getting PrEP out in the community, but Marina, do you want to talk first of all in Canada? One of the questions suggested there were nurse-led PrEP programs in departments of public health. Maybe you can answer that. And then one of the questions started says, what are the top 3 things that Susan would like to see implemented in the United States that haven't been implemented? So she can think about that while you answer.
Great. Yeah. Well, yeah, I think the thing is, despite our having a much less complex reimbursement system in terms of drugs, we still have a big implementation gap in terms of PrEP in Canada. And so even though there's been sort of a sharp uptake in PrEP since particularly the generics became available, there's still only estimated to be about 10,000 people receiving PrEP regularly in Canada and most recent estimates. So there have been some innovative attempts to try to expand that. The nurse-led sort of care model that you're referring to is, I think, originated in Ontario through some public health clinics where STI screening takes place or STI diagnoses are being made. And at that point of contact, the nurse that is, because these are reportable infections, makes the contact with the person and then offers the possibility of being engaged in PrEP. And it's actually been quite successful as a model that's been evaluated in terms of engagement. I think up to about 45 to 50% of people actually agree to kind of at least make that first attempt, and maybe 40% of them will attend a first visit. And then the nurses continue to lead the kind of care and follow-up of those individuals. And there's been several publications now about the acceptability and the uptake of it, which looks like a model that's now being more expanded within the province of Ontario. Obviously, there's going to be jurisdictional issues at different provinces, and if nurses have the ability to do these as delegated acts, for example, it depends on the territory, but it really does look like a model that's of interest. And I might mention just another one, which I think is really taking off, especially during COVID, which is the ability to get on online assessments for PrEP through a consortium of doctors, nurses, and other practitioners who've put together, a really attractive website, which is educational, but you can actually sign in, do a PrEP assessment tool online and get linked directly to a clinician in your province who can then get you onto PrEP and organize all the blood testing without ever having to see a physician in person or a person in person. And that's has been really taking off. So I think it's another kind of innovative tool that's countrywide.
Yeah, that sounds really great. Before we get to Susan, we haven't asked Hyman his perspective on this, but do you have anything you want to add in terms of things you'd like to see done to get more exposure to PrEP?
I think those are all important components. And I think coming back down to sort of choice and what works for one person might not work for another, and just giving people the options to access PrEP in ways that work best for them, both for uptake, but also for persistence. We have this huge problem where people are not on PrEP for that long in their sort of times in which they might be at risk for acquiring HIV. And so we have to think about both starting people, but also helping them stay on PrEP.
All right. Well, since Susan wanted to put you on the spot, what are the things you'd most like to see here?
Well, I would love to see a nurse-based program. There's absolutely no reason why there shouldn't be a nurse-based program for PrEP, and yet that's not really allowable other than nurse practitioner-based programs in the US. So in the same way that we've got collaborative practice agreements with pharmacists, I would love to see that happen with nurses. I'd even take it a step further. And in Thailand, they're doing peer-based PrEP administration. And I think it would be really interesting to see if that could get around some of the roadblocks that we have in reaching populations that have traditionally underrepresented in PrEP. But I do think one of the things that is sort of most key is what Hyman talked about in his presentation, which is really moving away from risk-based discussions and risk-based screening and offering PrEP to everyone who's sexually active, and really just describing it. So because you could see the knowledge levels among heterosexuals were exceedingly low, and getting PrEP out into syringe exchange programs or syringe services programs would also be really helpful. So I think we've got to really look at those populations we're missing and try to figure out what are some innovative programs we could use to specifically address those particular populations. And this express approach to monitoring has to be, it just has to be a lot easier than what it currently is, so that you could drop in at a laboratory, or you could do home-based testing as your way of doing your annual screen, your quarterly screening, and then only need to see a clinician or whoever's leading that program once a year, either face-to-face or telehealth for a check-in.
So instead of all this focus recently on citizens arrest, we can focus on citizens assist and let them help us with this. Yeah, that'd be great. Okay, so some more, Jeff, there were a couple more comments directed to you, and then I think we'll broaden it out, because I think we're segueing right into the panel discussion here. But if insurance company isn't covering the prep in the labs and the cost shifting you've gone through, the PA process, et cetera, what steps do you take next? In other words, if you keep hitting these roadblocks, what are the options?
So I glossed over this in the interest of time, but I did have a slide, and I mentioned that providers can help. But your recourse varies depending on the type of insurance you have, and I listed places you can go. You can also complain to the federal government. Like off the top of my head, I can't tell you where it is right now, but it's in the slides that people can reference for where to go to file a complaint. The other thing I would say is, I said this guidance came out over the summer, it became enforceable in September. So a lot of people may not understand that these requirements exist and that they're enforceable rights. So it may be you have to go back to the same plans that denied you before and say, do you know that you're breaking the law and you're facing an enforcement action unless you start covering this prep free of charge? And that might work. But you don't have to do this alone. So the slide I give, if people can access it, should give you some direction on where to go to file complaints.
Great, thank you.
I'm sorry, Jeff, I saw you typing away as to how you can magically get more PrEP access in states that have poor access. So what was your response to that?
So what I said is, I don't have the magic answer, but I think that the USPSTF recommendation really does matter. So I think we need to maximize it. Again, helping people understand they have enforceable rights. The health center money, it's $150 million of new money, health centers in all parts of the country. So you should leverage that. But I also said that, we have seen some successes. So look at the local resources of the Southern AIDS Coalition. I don't know what Mike's clinic is doing in Birmingham, but like My Brother's Keeper in Jackson, Mississippi, they're doing great things with PrEP. So what are the lessons they've learned? I wish there was one simple answer where I could say, turn to this program and it solves it everywhere, but that's not our case. So it's going to be a patchwork system we come up with, but there are things we can do.
Yeah, it's important that we all sort of stay active, and that is one of the challenges. Actually, it's one of the reasons for this whole webinar is to help bring these things to light, and having the perspective from other countries is helpful too. So I think we'll keep incorporating the questions. I think they're more broad now. And I don't know if we want to sort of break it down. I think we know who the populations are who are at risk. There are strategies that we heard described that talk about how you might focus on one or the other and how to overcome the disparities. But assuming that that's all done, and we can come back to that, I'm wondering, and Hyman, this kind of goes back to you, but I'd like to hear from the others as well, is just that pattern of keeping people in care once you get them engaged, making sure that things are going. So what do you do, Hyman, when you have somebody who's been on PrEP, they're supposed to come back for their visit, they don't show up? Do you have outreach? Do you have some way of tracking that? What do you guys do?
Yeah, so there's a variety of strategies. So, and we do this a lot with sort of panel management with other disease like diabetes, for example, hypertension. So it's the same idea. And I think for our work with prevention, there's not always the same motivation for things to be sort of coalesced around getting people back in. So we use a panel management strategy. So somebody is due for their 3-month, they missed that visit. There's an outreach effort to re-engage that person into care. We do the same thing with HIV. So we try to use those same lessons. And one of the side benefit of that, I think, is one, you identify other things going on with our patients, things that we had no idea were happening. Two is that there's a sense that they're cared for. And so there's this connection that you have to somebody is worried, is wanting to know how you're doing to bring you back in. And for a lot of our patients, particularly in the safety net, like that is their support network. And so that's been really, really helpful. With very large clinics, I think it's a little bit more challenging. So I think if you have 3,000 or 4,000 patients, if there's an automated system, if somebody misses a visit, to have some sort of type of outreach, but the benefits of it are, I think, significant. And then you can identify if somebody has stopped PrEP. We've had patients who've had their insurance change, and that's actually what's happened. And so they actually have stopped PrEP because of that. So there's opportunity to link them back into a place where they can get PrEP during that gap, or maybe they just didn't get the letter that they needed to send back, particularly for our younger patients. So there's a variety of things that come up with that outreach. That I think it needs to handle.
And it seems like, at least in my mind, when I first started hearing about all this, I thought, well, we have these specialized locations for focusing on PrEP. And then I thought more about it. And, we're talking about people generally between, let's say, and there are younger people, but let's say 18 and 35, who most of them, at least that I see, don't have routine healthcare. I mean, at least not in the US. And so the PrEP is actually an entree into the health system, right? And so are there services that you guys provide that say, oh, you've got a gastroenteritis, or your blood pressure's up. Can I get you referred, or can I get that taken care of? How many of you guys are doing that type of thing in a more comprehensive way of providing service beyond PrEP?
Mike, I think a lot of what we end up doing is incidental finding that as part of the PrEP process or the interview process to start PrEP ends up coming out in the wash. So it's almost collateral benefit, not collateral harm of engaging with the healthcare system. I do think the thing that tends to bring people in for routine care in that age group is STD testing. So, that's what you advertise, but you plan to provide as much as you're able to wrap around. But that's the draw, at least we have found.
Yeah. I mean, I think one of the major issues is that there's a number of really great clinics and practices that have made PrEP like a priority for their populations, and they're often centered in areas where there's the populations that they serve are close by, and they have many mechanisms to kind of keep people in care and engaged. But what we're really missing is the larger group out there that don't have necessarily easy access to those, or don't even see themselves as being at risk. And there was really a lovely study just recently published that looked at the 3 big urban centers in Canada, and the awareness about PrEP is really high in the gay and bisexual men, sex men population, but most of them didn't feel that they actually needed PrEP. But if you applied the clinical criteria for PrEP, over 50% of them would have qualified for PrEP. So there's this disconnect sometimes between, it's out there, it's for the other, and it's not for me necessarily. And how do we, bridge that gap and then make it easy to access, especially in communities that may not be so well served because they're not in big urban areas. So I think there's a lot of implementation challenges that, despite, it being there and accessible, it makes it not so accessible.
Right. So I have to, unfortunately, I hit up against something that was popped up at the last minute. I want to thank everybody. Dr. Masur and the panel will continue, but thank you all for joining in. And I think this hit every mark that I was hoping for with it, and look forward to hearing the feedback after the panel's over. Thank you.
Great. Mike, thanks for organizing so much of this. So let's go on to a couple more, a few more questions here. Amanda Costello has come back and wants to know what the panel suggests about PrEP uptake for adolescents in the 13 to 24-year-old. And maybe, again, we can start, I don't know who we should start with. Marina, why don't you tell us in Canada what you're doing about adolescents?
Again, I think that's a really underserved population so far. We actually recently had a good discussion about this in the Canadian HIV Trials Network, and you know, the pediatric groups are really trying to find ways to bring it in, but there's so much challenges in terms of stigmas around even just sexual activity in that group and a disclosure with their parents. And fortunately, in Quebec, at least where I'm based, sort of the age of consent for any medical intervention is quite low. It's 14 years old. And so that means that they do not need their parents' approval to get birth control or PrEP. So that actually has facilitated access to it, but then it's really much in specialized centers. And I think, again, we may be missing a lot of teens that could access it still, and they don't have really well-defined projects for it going on, as to my knowledge at the moment.
Let's see what the other panel members, Hyman, you want to make any comment about that, or you're welcome to defer to somebody else, depending on your experience?
Yeah, so I think one of the things that we've seen is, one, it's supporting providers so that they feel comfortable and knowledgeable to be able to provide PrEP. And then really addressing some of the access issues. So I volunteered at a clinic in Berkeley, and it's sort of a gay, bisexual male sort of clinic. And almost all the volunteers were out to their friends and family, and almost none were out to their family members. And so it just sort of gives a context of the complexity with younger people and the cost associated if Truvada shows up on an explanation of benefits to your parents, and they know you're gay, but they might not know you're having sex. And so it raises all these concerns. So really addressing that, and having some aggressive policies. So in San Francisco, we just bought Truvada and gave it to young people so that we could get around that issue, but really identifying where the gaps are to try to address them, because they are going to be different for younger people in the US for sure.
Well, before we go to Southern California, Susan, you want to say anything more about San Francisco?
No, I think what Hyman described is actually really important. I think the other thing is that pediatricians are trained, I think, to start at a certain age to get kids' parents out of the room and to discuss a variety of topics, including sexual practices. But we haven't really trained pediatricians to administer PrEP. And we need to do that because that is a place where teens, adolescents do sometimes go to their pediatrician for their annual visits. And it would be a way to actually at least educate that population about PrEP.
Yeah. Rafi, you want to add to that?
Yeah, I think it's something that we don't know how to, we don't know all the right answers, but we need to start somewhere. And, you know, I know the Adolescent Trials Network that did the registrational work that actually supported TDF FTC's expansion of its original approval down to allow younger and lighter weight individuals to get TDF FTC PrEP, noted that engagement is challenging. The additional wraparound support services when you're working in that population are really significant, that the retention and adherence challenges are amplified even compared to what we're seeing in young adults and older adults on PrEP. So it's actually an amplification of the challenges of scaling up PrEP in adults. And I think we need people who are really committed to figuring this out so we can do better. I am hopeful that as we get injectable or longer acting agents, that youth and young adults will be a population who will benefit disproportionately from access to those options that require less of a daily intervention, but it's still going to require the conversation, the access, the wraparound services. And I think working with pediatric specialists and adolescent specialists, where, you know, brain development is not necessarily always in the same place as chronologic age or sexual development age, it makes it really challenging. So we need people who work closely in these populations to help us figure this out.
Yeah, there are a number of questions about uninsured patients and the difficulty of getting them referred out and the interval at which they're at risk before they get referred to another center. Does anybody want to make any comments about how to provide services for these patients while they're looking for a home? Canada, it's not an issue, but Jeff, you want to say something about that?
I don't think there are any perfect solutions. We do have programs that can serve people that are uninsured, and including, undocumented immigrants and people that otherwise are ineligible, including the health centers. I think that people need to just look at the community resources and look for places. I don't know, I can say in the whole country, always go here, but like if you were in Washington, D.C., I would, could refer you to specific places that might be able to help you find the local resources. So you just have to do that in your own community. I mean, the other thing is we need to get every state to expand Medicaid, because the more states that do that, there's just more community resources to assist these other people that still fall through the cracks and remain uninsured.
But Jeff, this really is the challenge, right? You need to know your local geography, your local services, who is going to be friendly and culturally appropriate to the population, who's going to be geographically appropriate. And it's not a one size fits all. It's very fractured in the US, and it's so hard to give generalizations outside of sort of where you work.
And one thing I would add is, I think if a patient is talking to you about PrEP, they probably are comfortable with you as a clinical site, and that there's actually a lot of data, particularly in New York, that referring out, a lot of those individuals just never get on PrEP. And so I think, again, getting back to the barriers, and if somebody is having an engaged conversation with you or with your team about PrEP, then thinking about it, are there strategies or ways that it can be integrated so that people don't have to go to another place?
Switching topics a little more, there are a couple of questions about how often you do HIV testing. There are patients who are on and off PrEP. There are people who switch from one PrEP approach to another. I'm not sure there's a good one-size-fits-all answer, but just to pick on somebody, Hyman, to start with you, what's your general philosophy about HIV testing? Just do it as often as common sense would tell you?
Yeah, I do it every quarter. So that's generally what I tell my patients. Like, we're going to start at PrEP, and you might go on and off it, but if you're sexually active, just come in every 3 months for testing. We'll do HIV and STI testing. If you're off it for a while, like more than a month, and want to restart and have had some exposures, you can come in for additional testing. And so just try to make it as easy as possible. But for every quarter, just to keep it like simple and in line with our local guidelines for testing.
Is that what the rest of you do it every quarter?
Yeah.
I think it's very easy. It's very easy for people to conceptualize in that way. It's seasonal, right? It's a new season. It's time to get tested. And that makes it more acceptable. And that way you don't have to get into enormous complexity. If someone's on, if they're off, if they're using 2-on-1, if they're using daily, that's just the pattern of testing. Of course, as Hyman said, if you have something more provocative that's making you concerned, there's nothing with doing additional testing, but having that as your standard, I think makes a lot of sense from a number of perspectives.
Here's actually an intriguing question for Susan to maybe tip her hand about what the San Francisco Department of Health is going to find. But do you think when we see the data from 2021, the data will look better or worse in terms of new cases and uptake of things like PrEP?
One of the challenges that we have is that we saw a dramatic decline in HIV testing. And so while we saw, for instance, a decline in new diagnoses by 22% from 2019 to 2020, we don't know that we can actually trust those numbers because we don't know if we're missing people because there was less testing going on. So while the HIV testing has gone back up to baseline pre-COVID levels in clinical settings, in our community-based organizations, it still hasn't rebounded all the way. So my hope is that we'll continue to see a decline, But I think we're going to have done some backsliding because a number of people did go off of PrEP during the COVID pandemic. And sometimes that was because they were no longer having sex, but sometimes it was because they didn't want to go into the clinic, or the clinic wasn't open, or there were other access related issues.
Yeah, well, that's an important issue about the quality of the data.
Yes.
But Marina, do you want to say anything about, is Canada any different in those terms?
No, I think we experienced pretty much the same thing. There's a lot of closures, obviously, around the shutdowns in various provinces. And although we did start to see quite a rise in some STIs, and particularly syphilis, over the last 6 months to a year, which does suggest that despite, you know, the measures that were in place, people were still having sex. So we do anticipate that there may be a sort of lag phase and a rise that kind of catch up, unfortunately, in new HIV infections that will follow that. But we haven't seen the data for that yet.
Yeah. Now, maybe go ahead, Jeff.
I just wanted to jump in and comment. Like, I think what said, like, COVID could really be a setback, but I also think we're almost creating this perception that we know it was horrible without having the data. So I just think we need to temper how we talk about this. You know, I've heard that viral suppression is up in the Ryan-White program. So I just think before we like communicate too broadly how badly things were because of COVID, we need to wait for some of the data to come in.
I think that's a good point. You know, this is also an opportunity for the panel members to ask each other questions. Do any of you want to direct a question to one of your fellow panel members and see what you can elicit from them?
I was just going to make a comment. Oh, sorry, I didn't want to jump in.
No,
just
go ahead, Marina.
To follow up on the whole COVID situation, though, I think it also showed us a lot of opportunities that we ought to be trying to look to build upon. And, you know, I mentioned already that the online sort of programming, but the fact that we can do a lot more without having to physically see a provider, and has really taught us that we can probably facilitate for many people who either feel awkward coming to the clinic or have other constraints to facilitate PrEP in many innovative ways. And I think we really have seen that with other aspects of healthcare. And I think this is an opportunity to rethink our structures and our programs with respect to PrEP.
Jeff, what do you think is going to happen in terms of reimbursement for telemedicine? Because I think, you know, all of us can see the power of that. We're dealing with some of the regulatory issues, some of the electronic issues, but where do you see that going from your policy perspective?
So it's funny you asked me that. The short answer is I don't know. I actually am working on a paper on that topic. I did some things for a CDC's STD division. And I think we can all recognize that we had an emergency response and we need to move to something that's more sustainable. I think a lot of people want some of the emergency policies to continue, but I don't think there's clarity which ones. You know, we waived some HIPAA requirements. Should we waive them all going forward? I know most providers believe strongly that parity was critically important, and it probably is in the short term, but is parity of reimbursement for in-person and telehealth services something that can be sustained over time? So I don't think we know where. I think like in the context of STIs, I think we need to also figure out how to reimburse for a higher volume of services, taking into account that public health conditions might vary if we're having in-person telehealth services, and we don't know how to do any of this. When we tried to shift to different reimbursement models for like behavioral health, it's been a disaster. So I don't know where we're going, but I think we're all going to have to stay engaged because, you know, if the reimbursement's inadequate, we'll see a lot of harmful outcomes. So.
Marina, you want to comment on that from your perspective?
Yeah, I mean, I know here they kept parity for visits all the way through, and we're expecting it's going to change in the new year. That as there's a push to get people back in-person visits. That said, I think there's going to be a long-standing. I think it's going to become entrenched at certain levels for certain types of services, and especially these sorts of ones that don't require, you know, physical examination or really in-person visits. So I think we're looking for some sort of hybrid model, which is pretty much like the return to work is currently in our country anyway. Yeah.
That's good. Susan, there's a question about how we get public health departments to focus less on episodic care and more on long-term care, including PrEP. You want to make any comment about that?
Oh boy. Well, I think that if you can look at the potential impact of PrEP. That's where some of these models can potentially be useful. You can see how much you can drive down infection rates through PrEP, through something like PrEP, that you don't get from just episodic, certainly counseling, as I think it was Hyman pointed out, but other sort of episodic kinds of approaches. I think PEP has its place, but PrEP really has the power to actually move things. So, you know, to the extent that you can, what we did in San Francisco was built this multi-sector consortium that I think has a lot of power, because we've got over 300 members, and we incorporate people from the health department, from the universities, from Kaiser, from community-based organizations, activists, people, clinicians of all different sorts, all coming together. And, you know, if you can then try to create some consensus around what kinds of programmatic things need to happen, and then advocate for those at a city level, we've been quite successful in doing that. So I think that's, you know, but it does take sort of both some thought and then some mass of people, I think, to really move that forward.
Rafi, anything from the Los Angeles perspective on that?
No, you know, Los Angeles is challenged by enormous geography and siloing of communities that just makes any centralization of public health services especially challenging. You know, we don't have sort of an urban center that lends itself well to centralized services. So this notion of ongoing support for remote or telehealth services, even as things come back to a push to in-person, I think is really critical to success in our geography. And I suspect it might be a microcosm of what is true in more rural settings as well, where there aren't services that are easily accessible to communities that are widely dispersed.
All right, again, I offer one more opportunity for the panel members to ask each other a question.
Henry, there was one question that I saw come through about from one of the attendees of the conference about what people do, you know, when someone is in a monogamous relationship with someone who's living with HIV and they're on treatment and undetectable. And we all believe, of course, U equals U. And the person who's HIV negative in the relationship, despite ostensibly having an understanding of those principles of U equals U, still wants to go on PrEP. And I'd love to hear how others approach this. We've been sort of talking about this since sort of PrEP sort of began to be scaled up in the early 2010s. My approach is that if someone understands the principles of U equals U, and they still want to go on PrEP, I suspect that there's something that they're doing that is putting them at risk that they're not comfortable sharing with me, whether it's an extradiatal partnership or additional behaviors or something. So I've increasingly moved away from a position where there are a lot of cases where I would refuse to give someone PrEP who, after a conversation and they're able to understand how it should be used and what risks are or are not, and they still want it. I'd love to hear how others approach it, because it is predicated on being able to have a nuanced conversation about sexual behaviors and the data.
Well, that's actually a very important point about what the patient's not telling you. Does anybody want to pick up on that theme? I mean, I think that's obviously a good point.
Yeah, I think I've had situations very similar to that, and sometimes it's not only perhaps other relationships outside the partnership, but within the partnership, if the person isn't necessarily 100% adherent, and they're worried that there's going to be gaps in the U part, which we only measure periodically. I've got heterosexual partners that are serodiscordant and are on PrEP for that reason, because there's been instances in the past where the person has just stopped taking their meds for a month or so. So I think I agree with Rafi that the discussion has to be had, and people are intelligent and can enter into that discussion. And if they really wish to have PrEP, then there's no reason to withhold it. There's obviously a reason behind it. Yeah.
Yeah, I sort of take the same approach. I lead with a yes, like yes, we'll offer you PrEP, and want to make sure you understand what U equals U is, and that does no way impact my ability or desire to offer you PrEP. Because I do think that there are a variety of things that they might know that they're not sharing with you about their partner, about activities and other things that might be going on. And one of my favorite questions is like, what type of monogamy is this? Is this emotional monogamy, sexual monogamy, other types of monogamy, and how people define things? Just an opportunity to engage with our patients around that discussion. But I usually lead with a yes, because, somebody's asking for PrEP, and they have no contraindication, they're going to get it.
All right, well,
Hyman, could you say,
Go ahead.
sorry, Henry, Hyman, could you say a little bit more about that? Because I thought I had heard everything. I've said to people, monogamous is only monogamous until one partner learns it's not monogamous. That's sort of everyone's nightmare situation. And I've heard of the term monogamish, but I've not heard this distinction that you're making that I think is really, it's striking a chord with me. Could you talk a little more about how you approach this idea of emotional monogamy versus physical monogamy with patients?
So the way that, and a patient actually taught me this, the way I talk about it is like guest stars. So are there any guest stars in your relationship? And that is somebody who might come in once or come in and out more than one time into the relationship. And then, when I ask about monogamy, I actually don't use the term monogamy. I sort of ask about it in sort of this guest stars type of way, but it sort of gets at, this is my partner and I don't fall in love with anyone else, that is part of our relationship. But there might be physical things that happen outside of the relationship, either when whatever the rules are that they may have had, spoken or unspoken. And that there's often a distinction about the connectivity and that connection, and the way that people with their partners have different levels of emotional connection. And that sort of, for some people, is monogamy. They have a monogamous emotional relationship, even if it's not a monogamous physical.
Actually, there are a lot of interesting concepts that we're getting out of this symposium today. Jeff, I know that you're typing the answers. Do you think there's any chance that in the U.S. we're going to support nurse or pharmacy-based PrEP services?
I don't know what it means to say support. I think people are looking for innovative models. And I think if we learn more and saw more research about how effective they are, that could lead to the adoption. I think when people ask these questions, it's almost like we're going to get an edict that, these programs are suddenly going to require the adoption. That's not how our system works. We have a federal system. So like in Medicaid, we pay claims. We don't tell states what to do. We give grantees lots of leeway. So I think we can lead people to innovative approaches. And I think that's how we make change. But I don't know that there's a way like we're going to necessarily adopt some sort of like nationwide approach to use nurses and pharmacists. But am I understanding the question correctly?
Well, I guess you can see what kind of response you get back when you type that.
Right.
Let's actually maybe end this symposium with a particularly difficult issue, and that is, how do you get patients who inject drugs into the PrEP continuum? And I suspect that in Canada, they've solved this problem. So Marina, why don't you start?
I only wish that were true. Yeah. So it's obviously long been recognized as an important group of people for whom we need to develop strategies. And I think one of the places I've most had experience with is in Saskatchewan, where there's a large growing outbreak of both HIV and hepatitis C, particularly among Indigenous peoples who inject drugs. And they're really trying, the most success we've had is with the partners of people who've recently been diagnosed, to approach with them, okay, okay, this has happened. You're negative now. Can we do something to try to prevent you from becoming positive? And there it's a mixture of injection, drug sharing, and sexual exposures, and had some limited success with that. But it's really been difficult to have a systematic approach across these groups because of their difficulty in remaining engaged in care for a variety of socioeconomic reasons. And that, I think that's true in Vancouver. There have been some pilot projects that have been successful. So, we're trying these things linked with methadone treatment, for example, but they're all in small pilots as far as I'm aware, and no systematic approach that's really been in place.
Yeah, so Hyman, what are you doing? Or Susan, looks like you were going to say, what do you do in San Francisco?
I think that we're struggling with this issue. I think if we can try to incorporate this with other substance use services, that's really the best way that we can get services out to this population. But it's been really challenging. So we're really starting to try to incorporate PrEP services in with syringe access services, in with naloxone related services. We're going to be trying a variety of different things, and we'll see what actually sticks.
Yeah, you want to add anything to that?
No, I think colocalization with current services. I've been really thinking about, the role of integrating PrEP within safe consumption sites as those roll out, and what benefit that might have, sort of really meeting people where they are to support their prevention needs.
Yeah, well, that's certainly in DC what we've been trying to do is meet people where they are and co-localize, but I think we're probably just following the lead of what you've done in San Francisco and Los Angeles. But Rafi, you want to make a final comment on that?
No, I certainly think one-stop shopping or co-localization of services is the only way this is going to be successful. I think many on this call or in the audience are aware that there's an increasing interest in mobile vans to try and deliver substance use treatment services and either HIV treatment or HIV biomedical prevention services in a one-stop but moving location, and that's being evaluated in a study that the HIV Prevention Trials Network is currently sponsoring. But I think we're all struggling to figure out, as Susan said, what's going to stick in people with substance use disorders or specifically injection drug use behaviors. It's challenging, and I don't think we've figured out what the right answer is yet.
Mm-hmm. Well, I think this looks like the end of the questions, at least that I can see in the Q&A. But I think this is one of the questions I hope that the registrants will answer for Donna Jacobson and her staff is what you think of this focus with an entire symposium on PrEP, because I think this has been very valuable in terms of looking at this comprehensively. It's clearly something that needs much more focus. And I would hope that IAS-USA would want to do this at least once a year to get this group together and to readdress this, because I think we've seen a lot of really fascinating new scientific approaches of drugs and long-acting approaches. We've seen a lot of innovative models to personalize this to different patient populations. Jeff has talked to us about how policy is going to change. I think that's something we all need to know about. And actually, some of the behavioral issues, I guess we all were particularly enamored with what Hyman had to say about how you might define monogamy. That's something that's going to stick with me. But I think everybody had sort of a different perspective. So I think it's been great that everybody shared their experience, and it's exciting to see how many different opportunities there are. But since Mike Saag isn't here to have the last word, Donna, you always have the last word. So do you have the last word for either the faculty or the registrants?
Unfortunately, Donna had to leave the call already, but we do have the closing slides that I will put up. And if anybody has any last minute comments, thank you so much for this amazing course.
Okay, good. And again, IAS-USA staff has really done a wonderful job putting this together. Because again, the uncertainty of knowing whether we're going to be live or only virtual required a lot of flexibility. But Stephanie and Michelle and the rest of the staff have really done a terrific job. So is there anything, Stephanie, you want me to say to end this